All right. Hello, everyone. Thank you for joining us. I'm Megan Ramsey. I help manage this Neuro-EM program, and today we have Roger Lewis with us, who will be presenting on statistical issues in grants and manuscripts. We'll give it just a couple of minutes to let a few more people join, and then Roger will get started. So if you have any questions throughout the presentation, you can always put them in the Q&A box, and I'll be monitoring that to let Roger know if there's a question he needs to answer either during the presentation or we can wait until the end.
Right, thank you.
Right, it looks like we have a good group of people, Roger, so I think we could go on and get started, and then I'm going to turn my video off, but if anyone needs anything from me, you can put it in the Q&A box or the chat.
That sounds great. Well,
Thank you,
everyone. I'm Roger Lewis. I'm an emergency physician out in California. I do most of my academic work in statistical design and analysis of randomized clinical trials, quite a bit of editorial work. And today we'll be talking about statistical considerations that come up in grant applications and manuscripts. And I assume someone will yell at me if they can't see my slides. These are my financial disclosures. Particularly pertinent to this, I am the senior medical scientist at Berry Consultants, which is a statistical consulting group that works in clinical trial design. I appreciate the support that we've had from NIH and specifically NINDS, and I serve as the senior statistical editor for the journal JAMA. So, in otherwise high-quality medical research, and what I mean is in research that's asking questions about important clinical conditions and treatments, the missteps in the statistical design and analysis often falls into several broad categories. The first is the lack of discipline and rigor in the evaluation of the motivating or preliminary data, that information you present to explain to the reader why this question was worth asking. The second category is the overall structure of the experimental design and the associated analyses. The third is the quality of the study implementation. How well did you actually do what the statistical design said you needed to do, and the assessment of the sensitivity of your study results to any deviations from the original study plan, and then a number of things that have to do with ensuring the reproducibility of results. Maintaining adherence to pre-specification of the statistical design, management of multiple testing or other sources of increased rate of false positives, and complete and transparent reporting of your results. Notice that none of these things have anything to do with p-values or choice of statistical test. They are sort of bigger picture issues about the scientific method and how we apply statistics to the scientific method. And I think the most important caveat for this talk is that all of this are observations and opinions, but it is based on reading a lot of manuscripts and writing and reading a lot of grants. In trying to put this talk together, I realized that I was going to be saying the same things over and over again with respect to statistical issues in grant preparation and in the manuscripts that ultimately present the results of the research funded by those grants. But it's important to understand the longitudinal trajectory of your design, because at the time of grant preparation, you're in the position of planning the full life cycle of the project, from the initial data collection through analysis, through first major publication, through secondary publications. By the time you get to manuscript preparation, it is usually too late to fix any mistakes or missteps that were made in that original conceptualization or structure of your analysis. But even with that in mind, you want to do everything you can during the life of your project, again, from the submission of your first grant through your final publication, as if there was someone looking over your shoulder and making sure that everything was, if you will, by the book, meaning you were making decisions that are consistent with rigorous scientific principles like adherence to pre-specified analysis protocols. And specifically, you want to consider that an auditor, if there was such a person, would have access to all your prior versions of the grants, the protocols, the data sets, the things you sent to various IRBs, the analyses that you used, the analyses you didn't use, and the manuscripts. And if they looked at that entire picture, would the entire picture be one of a well-structured, rigorous, and disciplined scientific investigation? Now, there's a lot of documents, and you'll notice that I'm going to be framing this in terms of a randomized clinical trial or a prospective clinical investigation, although much of this applies to animal work, it applies to observational work to a large degree, but I just use prospective clinical research as the example. So in a clinical trial, there's the applications that you submit to get funding, whether a grant application for a grant or a proposal if you're pursuing a contract. And then there's a set of documents that ideally you prepare at the same time that lay out in detail the actual clinical investigation that you are intending to get funded. And it's the clinical trial protocol, the statistical analysis plan, sometimes a manual of procedures or the DSMB charter. It is those additional documents that lay out the necessary details so that someone else could take your work and run the same trial that you intended to run, because all of the necessary pieces are actually defined and described. So in addition to the grant applications and the set of documents that form the entire protocol, there are actually, let me back up for a second. One of the challenges in your grant submission is that in the application, or in the case of a contract, the proposal tends to have very strict limitations. The people reviewing your grant are only going to be able to assess that you've really thought out the details if they have access to that additional detailed information. So whenever possible, you want to make those protocol-specific documents, the protocol themselves, the SAP, and additional documents, at least available to those reviewers who are motivated to find them. So you can have a clinical trial website, and you can provide the URL for that within the body of your grant. If the grant mechanism allows, you can include these documents as appendices, and know full well that the reviewers are not obligated to look at anything other than the body of your grant. However, good reviewers, or for example, the methodologic or statistical reviewer, will generally be motivated to look for these additional details to answer questions that couldn't possibly have been answered within this page limit of the parent grant. In addition to these documents, there's the manuscript. And the manuscript that you submit obviously presents, if it's the primary manuscript, the primary results of your investigation. But there are going to be a set of appendices, ideally, that again provide the additional detail on the statistical plan, any changes in the statistical plan from inception through final analysis, et cetera, that are going to be necessary in the manuscript review process. And I just want to emphasize that the different documents have different purposes, and therefore there is both a different level of detail regarding the statistical information in the different documents, and you cannot, in general, use the text from one document and copy and paste it into another, because it won't be fit for purpose. So, for example, if you look at the row that says statistical analysis plan for final data, the grant is going to have to provide that in some detail, but the statistical analysis plan is where all of the details regarding, say, the handling of missing data, sensitivity analyses, et cetera, would be located. If there's an interim analysis plan, for example, in a group sequential clinical trial, that may be only briefly described in the grant, but the specifics would be included in the SAP. So the point here is that these documents have different purposes and different amounts of detail. And if you just copy and paste, you'll be providing too much detail in some, losing space that you need for other things, or not enough detail in others, leaving questions unanswered, and therefore your approach open to criticism. So let's talk about how you think about the statistical design, for example, of a clinical trial for a grant. So you want to think about establishing a set or hierarchy, meaning an ordered set of goals that you can roughly divide into primary, secondary, exploratory. And the idea is that you understand the false discovery or type 1 error risk across these set of goals. There is a trend to move an extraordinarily large number of endpoints into secondary goals or exploratory, and they look like a laundry list of very closely related things. I was just looking at a manuscript where they evaluated mortality at 90 days, mortality at 30 days, mortality at 6 months, and then they looked at, in hospital mortality. And all of these things are just different ways of looking at the same thing. They don't therefore represent separate scientific questions to a large extent. And it appears that the people developing the statistical analysis plan weren't thinking clearly about what the different analyses were telling them about the effects of the treatment being evaluated. So you don't want to do that. You want to have each goal and the associated hypothesis represent a scientifically distinct and important question, with the order of importance roughly going from most to least. So avoid re-asking the same questions or asking questions of diminishing importance. And what I mean by that is, don't at the end be asking questions about, a quality of life measure at 1 year in the treatment of patients in which the majority of them die within 30 days. It's just, it's not going to be sensitive to what you're trying to achieve in all likelihood. And especially consider the contingencies or dependencies of the questions you're asking in your scientific or experimental design. If the answer to the first primary question is negative, the treatment doesn't affect outcome, do the second and third questions become irrelevant, or do they stay equally important or even become more so important? And I can picture situations where all of those are true, but you want to show that you've thought of them. So for example, you may say if the primary result to the treatment effect is negative, then in order to better understand the failure to improve outcome, we will then look at the following mechanistic endpoints to understand whether we were able to achieve target engagement, pharmacokinetics, whatever it is. The primary description of your study population, the intervention, if that's applicable in your data collection, is the foundation for everything else. So in every one of the specific aims and the hypotheses, the statistical hypotheses you pose relative to each specific aim, make sure that you can go back to your data collection description and there's nothing missing in your description of data collection that would be necessary to address those specific aims. All of this is making the point that the structure of your experiment needs to be complete and tightly integrated to convince the reviewer that you've really thought about how it all fits together. One of the problems people sometimes run into, and I'm going to try to not overemphasize this, but is inconsistencies between documents. So if you read your grant application or the clinical trial protocol that's either posted online or included as an appendix, make sure that although they may provide different degrees of information and emphasis, they never contradict each other, because any inconsistencies suggest that your left hand didn't know what your right hand was doing. It takes time to make sure that these things are all consistent. And this is one of the reasons a reader can tell whether a grant application, or in many cases, a manuscript, was put together in a hurried fashion. Now, there may be some cases where there are some very minor discrepancies. It may be useful to define a hierarchy of documents. So say explicitly in your protocol that if there's a discrepancy between a description of the statistical analysis and the protocol and the SAP has precedence. You want to maintain version control. So every time you change your protocol, as you move towards implementation or completion of your trial, you have a record of what you changed and why and when the new version went into effect. So now returning to those general categories of missteps that can occur during the grant application and often in manuscripts. The first is a lack of rigor in evaluation of the motivating data. So in your introductory section, whether it's in a grant or a manuscript, you usually present a summary of pre-existing data from others, or sometimes in a grant, your own preliminary data, which you're using to suggest that the experiment that you're proposing or the experiment that you've completed is an important experiment to, and an important question to answer. Those evaluations tend to be very sloppy with when compared to the analysis of the actual new data. So you want to think specifically about multiplicities. Have you really looked at all of the information that's available that would help to either establish or frankly disprove the importance of the question you're asking? Make sure that it doesn't look as if you've selectively considered only those studies that support what you propose, because your reviewers will know about your field in general, or they can do a search as well as you can, and they will find that you're ignoring a whole bunch of negative studies that suggest the therapy won't work, or the question isn't interesting, or even worse, the question's already been asked and answered. And I will tell you that grants often live and die based on the quality of the analysis of motivating data, in the sense that if you convince us that the question is critically important, reviewers are often willing to give you more leeway in slight lack of perfection in your plan for addressing it. But if you don't convince us the question is important, a perfect analytic plan will not get you funded, because we will not care about the correct answer that you will ultimately obtain. And I want to specifically say that you want to be careful of false associations, because it is very common in proposing prospective clinical research to use as your motivating example findings of associations. The ingestion of a largely Mediterranean and plant-based diet is associated with a decrease in cardiovascular risk. That may be true, but that doesn't mean that changing someone's diet is actually going to change their risk. It's probably a poor example, because there probably is some causal effect there. But a huge amount of the effect is the confounding, because people who in observational work choose to ingest a diet of that kind take other steps that also modify their cardiovascular risk profile. So that is a form of reverse causality. There's also cases in which there's immortal time bias, where in observational data, in order to get into the observational data set, you actually had to live long enough to have the diagnosis made, for example, or live long enough to find out that you would qualify for a proposed future treatment. So just be aware that most observational data that demonstrates association, in fact, cannot rigorously support a conclusion of causality. And therefore, you need to be very metered in the way you present this to show the grant reviewer that you understand where there is solid information supporting the hypothesis you want to test, and where that information is more tentative. So each specific aim should be uniquely tied to a specific data element or outcome, meaning don't have 12 specific aims, each one of which are just different ways of looking at the same outcome. There should be, in general, either an associated hypothesis to be tested or an important parameter to be estimated. For example, we want to establish that in this animal model, the percent binding at the receptor site is at least this amount, because that would be a prerequisite for further, development of the intervention. You want to have the ordering of the specific aims be such so that each either builds from an earlier one or supports later specific aims to the extent possible. As a general rule, if a specific aim just stands on its own, its relationship and importance to the overall structure of the scientific endeavor is less clear. If there are contingencies, this aim is only important if this other one is positive, say so and what you're going to do. And it's perfectly fine to say this specific aim will only be addressed if the specific aim above yields a positive result. Okay? Don't have specific aims that ask obvious questions. In other words, only ask questions that are worth asking. It's not useful to have a specific aim that everybody knows you can achieve just so you could have one positive result. Make sure your data definitions are precise, measurable, and to the extent possible, reliable and previously validated. That can't, the previously validated is not always possible. Okay. So what are the methodologic problems that we see that go beyond the fundamental structure of the way the experiment or the clinical trial is set up? So the first is unrealistic effect sizes, where it's absolutely clear that the investigator figured out they could enroll some number of patients and then back calculated the effect size that gave them 80% power for that effect size, and for that population. We all do this. We all know everybody does it. And when you see it, you know that the trial is simply not set up to definitively answer the question, because in the general likelihood that it will be negative, it may not yield a precise enough estimate of the treatment effect or parameter in order to unequivocally answer the primary question. The second would be a lack of consideration of and sensitivity analyses for other design parameters. What are you going to do if the event rate in a survival study is too low or too high? What if the loss to follow-up rate is higher than you expect, et cetera? On a very related note, you want to make sure you have a plan to minimize and address missing data. Patients who are lost to follow-up, for example. The most common is multiple imputation, which is generally a good first approach, and never, ever suggest complete case analysis, single value imputation, or last observation carried forward. Those are just not tenable in modern research. You want to anticipate where there might be deviations from your planned study populations. Very common to design a clinical trial on an assumption that say a mortality rate will be something. And then when you start to enroll patients, you find out the patients that are well enough to enroll and consent and return for follow-up actually are less sick than the observational cohort on which you based your statistical design. You want to anticipate what are you going to do if the enrolled population doesn't match your assumptions. Do you have a way of increasing the number of sites, changing the enrollment process? And if you're losing patients to follow-up, do you have a way to having a multi-step follow-up plan where if I can't get them back for follow-up, at least I'm going to call them, or at least I'm going to check the Social Security death index, or whatever it is. And you want to have a plan for testing the sensitivity of your primary result to missing data, such as a tipping point analysis.
Roger, sorry to interrupt. We have a question. I wanted to see if you want to answer it now.
Sure.
The question is, I feel like I've been told frequently to not have aims dependent on one another, and they're wondering if you can speak a little bit more about when that's actually okay.
Yeah. So the reason people tell you to not have specific aims dependent on another, and I noticed there were a number of faculty on, so if anybody has a different idea, I'd love to hear it. In my view, is because they worry about a criticism that if the investigator fails to achieve specific aim 1, for example, the rest of these are irrelevant, and what are they going to do with the money? But my argument is that science is just not like that. And in fact, what you do next really does depend on your first result. But the point is you have to have a plan for that. If you leave that unaddressed, it's an obvious fatal flaw, because then your entire endeavor becomes, or at least much of your endeavor becomes, contingent upon success of an aim whose outcome is not known. Well, what I'm saying is have a plan for what you're going to do if you have a negative result. Explain what that plan is, and it's perfectly fine to have contingencies where a specific aim is only relevant depending on the result of a prior specific aim. To me, that's a more accurate representation of how science should progress and shows you've thought it through. So I think what you're being advised not to do is to fail to explain is a strategy in which you make yourself vulnerable to a failed specific aim, but don't explain what you're going to do about it. And I would agree that's not a good idea. I hope that's helpful. Other common methodologic problems are a lack of clarity in a hierarchy of endpoints. So you may list, and I see this more and more frequently, it'll say the primary endpoints are A, B, and C, and the secondary endpoints are D through Z. And never does it tell me whether there's an ordering to the hierarchy of endpoints, whether you have control of your type 1 error, or you're just going to test everything and see what happens. And a subset of that is this phrase co-primary endpoints. It is my observation that in many academic settings, the term co-primary means I have two different things I want to change, say, a pathology score, say in an oncology study, and some quality of life or overall survival. And I want my trial to be considered positive if either of those results are positive. If you do that, you're going to have to split alpha or some way control the multiplicities. The FDA thinks the term co-primary endpoint means both of these have to be positive, and if either one is negative, the study is negative. So it's the exact opposite interpretation of the term co-primary. The point is not that one use of the term is right or wrong. It's that failing to explain exactly what you mean and have that logical structure embedded in your statistical analysis plan would leave you open to criticism. Another is the use of outdated statistical methods. There's a set of methods that are frankly only useful for historical context and telling people what not to do. Things that come to mind are 3+3 dose escalation, dichotomization of continuous or ordinal endpoints, although I will point out that neurologists are still burdened by literature in which the MRS is dichotomized for, as far as I can tell, no apparent reason other than convenience. As I've already mentioned, last observation carried forward. These things are antiquated and inefficient ways of analyzing data, and therefore you don't want to use them. You also want to avoid having your grant have stock paragraphs that are clearly statistical analysis verbiage that's used from grant to grant. It starts by saying, all data will be analyzed according to intention to treat. We'll summarize continuous variables with means and standard deviations and categorical with percentages. And we'll use Fisher's or chi-squared where appropriate and blah, blah, blah. None of that tells me anything about how you're really going to analyze the data and whether you've thought it through. If the statistical analysis section doesn't look as customized and fit for purpose as the rest of your grant, it will be a net negative. And I will say that all of these issues that I've identified in the last two slides are often due to a structural problem in the research team, which is the lack of the full inclusion of the research methodologists on the study team. So if you can partner as a full research partner with a statistician or research methodologist appropriate for your area of interest, and include them from the beginning and develop a mutually supportive partnership, then these things will take care of themselves naturally. If you write your grant and then send it to a research consulting service in your stats department that gives you 2 hours of free consulting and ask them to write your grant, then you'll get something that looks like a lot of other grants that show a lack of integration of the research methodology with the overall scientific context. Now, having said all these things about the importance of pre-specification and laying out what you're going to do in advance, it's important to acknowledge that it's unrealistic to assume that once you get funded and you run a clinical trial, there will be no changes to the statistical design or analysis plan. And the grant application and the associated protocol you submitted initially is the starting point for that evolution in your project over time. So you want to make sure as it does evolve for whatever reason, that all the changes, revisions, amendments to the protocol, the SAP, are documented with dates, rationale, track changes, because then that collection of documents form the roadmap for understanding the project's evolution. And I can tell you in the review of manuscripts, understanding those changes is critically important to assessing the reproducibility and the rigor of the investigation. I do want to very quickly point out that a clinical trial design is incomplete without a statistical analysis plan. It is virtually never sufficient to include this in the protocol itself. I mean, in principle, you could, because there's generally no page limits on protocol, but the reality is the necessary detail is rarely in protocols. There is a little-known communication written about statistical analysis plans. By the way, all of these slides will be posted indefinitely and made available to you, so you can come back and look at this if you'd like. In addition, you may want to have what's called an MOP, a manual of procedures, and you want to implement your study as consistent with the protocol and the manual of procedures as possible. You want to minimize deviations, violations, minimize missing data. You want to be constantly monitoring your data for completeness and quality. Don't do that just near the end where you think you're going to start writing up your results. And it's worth spending about an hour on the web and looking up quality by design as a phrase in clinical trials, because it talks about strategies for helping ensure that when you get to the end of the clinical investigation, you find that your data are of high quality and they support the kind of analysis and the kind of journal that you'd like to be published in. The analyses plans for your study should include pre-specified approaches to test sensitivity to the results of the deviations that nonetheless will occur, like loss to follow-up. And I've already mentioned missing data. The model assumptions are things like looking at the goodness of fit of your regression models, looking at data distributions to see if they really look normal, and even considering alternative analysis strategies to make sure they give similar but not necessarily identical results. Okay, what I'm going to do now is I'm going to switch to focus on reproducibility of research, because almost everything that I've said so far is indirectly related to this, and almost everything that has to do with the review of manuscripts with statistical design actually is aiming to ensure reproducibility of the results. So I would like to just make sure that everyone knows about this NIH publication on enhancing reproducibility through rigor and transparency. Again, it's a document you should know about, and you should have a section on reproducibility and rigor in your applications, and you should use the terminology and cite this source to show you know what these terms mean and you've considered them in your design. Reproducibility in here is the extent to which the study's results can be duplicated. For example, if you did the trial or the experiment again. Rigor is careful use of the scientific method to make sure the results are unbiased and well-controlled, things like double blinding, randomization, etc. But all of these are aimed at trying to help us get the actual right answer to the question that motivates our investigation. I put the JAMA network at the bottom here. These are slides that have been given in presentations related to my role with JAMA. There is a second document that you should probably know about, which is the National Academy's report on reproducibility and replicability in science. And I just want to point out that this committee uses the term slightly differently. Here, reproducibility means if you take the exact same data set and you simply run the analysis again, you get the same results. It's more like computational reproducibility. What we normally mean by reproducibility in more informal language is what they call replicability, meaning if you address the same question, but with a new clinical trial, new set of animal experiments, maybe in a new laboratory, do you get the same answer? That's replicability. So reproducibility is the original data and computer code. Replicability is a new independent data collection to test for consistency with the prior result. So what are the things that make clinical research might not be rigorous? So some of it has to do with those basic elements of study design, like randomization, double-blinded outcome assessment, covariate adjustment, that just improve the chance that we get a valid estimate of the treatment effect that we're trying to measure. Some of the reasons clinical research might not be reproducible, meaning that you tried to run the same trial again, but you got a different answer, is if there's a lack of clear and detailed definitions of the study protocol, procedures, and analysis. So two different well-meaning and qualified investigator teams might actually end up doing it a little differently because it wasn't defined well enough how the experiment or the trial was intended to be conducted. And then the second is failure to adhere to study protocol, procedures, and analyses, especially if those deviations especially from the analysis, are non-random, meaning you actually changed something about the analysis in a way that was motivated by the data themselves. So I've tried to avoid equations and normal stats speak here, but I want to digress for a second and make a very important point about why you cannot use the data you've obtained to figure out how to analyze those data. You have to have a pre-specified plan and stick to it. So I want you to consider a randomized double-blind clinical trial evaluating a treatment in, the treatment is called X, might be yes or no for whatever you're testing. Patients have characteristics Y, which is all their baseline covariates, illness severity, prior treatments, et cetera. And their primary outcome is whatever it is you're trying to change, survival, pain score, whatever it is. And the data that you obtain in your clinical trial actually is the Z, the outcomes each patient has, but the contributors to the Z are multiple. There's the true effect of the treatment on the outcome, whatever that is, whether there's an effect or not. There's the effect of the patient characteristics, how sick they were, for example, when they come into the emergency department, on their outcome. And then there's just random noise. Sometimes in a trial, you enroll some patients who, for whatever reason, measured or not, tend to do better or worse than you might otherwise expect. That random variation or noise looks the same in the data set. It affects the outcome Z, and you have no idea which patterns in the data are because of treatment effects or due to noise in general. So in order to avoid being misled by that random variation, your statistical analysis must not be driven by the observed data with its random components. And here's why. So the idea is that the patient baseline characteristics, the treatment you administer, and just some random chance all affect the data that you observe. In a properly designed trial, the outcome data do not influence the analytic strategies and decisions. Those are pre-specified. The only thing that happens is the data are transferred in order to analyze and get results. This is a pre-specified analysis. It is valid. And Megan, I'm going to assume that if I should stop and answer whatever the second question is, you're going to break in and tell me.
I think, so Regina and Cliff, please weigh in if you want us to answer them soon, but I thought we could wait till the end for those.
Okay. The contrast for pre-specified analysis, which you may all think, oh yes, this is what we always do, is actually something that looks like this. And it happens not because people are trying to cheat. It's because they are honestly motivated by doing what they think gets them the best answer. So what happens is, notice I've taken away the little bars here, and now the outcome data in some way change the analytic strategy. So let me give you an extreme example, which you would never do, which is you collect data and you compare the control in your treated group, and you decide to analyze the data only when the treated group is doing better than the control. Now, obviously, that's a source of bias, and you're predisposing to get a positive result. Although I have to say, in right now in popular media, you see a lot of examples of people choosing to analyze only the data or present only the data that supports their preconceived notion. But obviously, you wouldn't want to do that. But let me point out what happens. What happens is that if you have an analytic strategy that is influenced even to a minor degree by the details in the outcome data, such as the variables you choose to adjust for in your model, you decide to determine based on whether or not they are statistically significant between treatment groups. So the idea, you have a randomized trial. In table 1, you're comparing the baseline characteristics between the two treatment groups, and you decide you're only going to adjust for those that are statistically significantly different between the two groups. If you're doing that, you're letting the actual data from your trial determine what your analysis model looks like, and that is fundamentally a bad idea. And it's a bad idea because it creates this dashed pathway, that was a mixture of dashed line and pathway, between random variation and analytic decisions, and that will tend to exaggerate random variation and lead to non-reproducible results. So the statistical evaluation of your grants and your manuscripts is often focused at making sure that there was only this situation with complete pre-specification, and there weren't any decisions about the analytic strategy that were made once the data were known to the investigators or those doing the analysis. And that pathway is a major red flag. Okay. And the reason it's a red flag is because investigators are not random. You don't just randomly look at noise and do something random in a change to your analysis plan. What you do is you modify your analysis plan to increase the chance you get the result you were hoping for, and that creates a feedback loop. Now, statistical methods can address the random variability. That's in fact what they're designed for. Statistical methods can address the impact of baseline prognostic factors. But what they cannot adjust for is non-random changes to the analysis method that are motivated by an awareness of what those will do to the results. And I will tell you that when I've worked with investigators who, with all sincerity and good intentions, want to modify their analysis plan based on what they're seeing in their data, and I ask them, why do they think that's okay? They say, well, now that I've seen the data, I would have selected that pre-specified analysis as the pre-specified analysis plan anyway. And of course, if they say that, you want to ask, well, why didn't they? But I just want to tell you, there's no one as creative as a clinical investigator who wants to believe that the result they want is the result they should have gotten. So now I'm going to switch gears in the last few minutes and talk about manuscript submission. And manuscript submission and the materials you provide, and then the review that it undergoes, is largely aiming at looking at the various sources of bias and non-reproducibility or non-replicability that I've already brought up. So I'm going to borrow from a presentation that I give in my role as a senior statistical editor at JAMA. And I want to point out that at high-level journals, and most mid-tier journals as well, your manuscript will be sent to a dedicated methodologic or statistical reviewer if it's competitive, and that person will look for sources of bias or non-replicability. So we look for bias from design decisions that are informed by anybody who knows the data, separated by treatment group, for example, the DSMB, because we don't want this pathway where the knowledge of the difference between the groups influences what we decide we wanted to analyze, and then that leads to results that are not factual, are biased, or non-replicable. We also worry about hidden multiplicities, and I'm going to be very explicit about that. So when you do multiple hypothesis testing, You all know that you often have to apply some sort of statistical correction to reduce the overall chance of a type 1 error. So, for example, a Bonferroni correction or a Hochberg correction. But what is especially problematic, and frankly has been a major contributor to the non-reproducibility of science, or the so-called replication crisis, is hidden multiplicities. And there's something like this. Let's suppose I have a study and I have a pre-specified analysis, and when I do it, I get a non-significant result. It's somewhere, if the p-value is 0.2. But if I adjust for a different set of covariates in analysis 2, it becomes statistically significant. And if I analyze it with a very particularly carefully chosen regression model, I can get a highly statistically significant result. If analysis 1 was pre-specified and analysis 2 and 3 are post hoc, analysis 2 and 3 have essentially no role in a publication in a top-level journal. But what's especially problematic is if what's submitted to the journal looks like this, where there's in fact a single analysis that is described as if it was pre-planned. For example, it's just described in the methods, and analyses 1 and 2 are hidden from the reviewers. Well, in order to figure out if that might be true, we need to look at the original clinicaltrials.gov registration, or the original protocol, not your final version, but your original one, to see what the original analysis plan. Similarly, let's suppose you have a primary endpoint that's not significant, and then 2 ordered secondary endpoints, and it is the second secondary endpoint that leads the most impressive treatment effect. Sometimes when you read the manuscript, even if all 3 endpoints are mentioned, it's presented as if that second secondary endpoint is clearly the most clinically important, and it's what gets most of the verbiage in the end of the abstract, the results, and in the final conclusion. So that's selective emphasis. Those are both ways that distort the overall negative result of the clinical trial. Now, there's a wide range of clinical reporting guidelines for various sorts of clinical trials at the Equator Network. You should all be familiar with the consort diagram and the consort approach. I want to just point out that the consort diagram is essentially a way of making sure that all of the reasons that there are post-randomization exclusions of patients are laid out, so the reader can judge whether those are likely a source of bias in the data that were ultimately analyzed in the trial. Again, a major source of non-reproducibility or of results. So in reviewing a clinical trial, at least at JAMA, we look at the manuscript, and it has these sections in it as a general rule. But we really look at the study protocol, and we look at the study protocol specifically for those to set the gold standard, if you will, or the criterion standard for those bolded areas. So if there's a discrepancy, we assume the study protocol is right. We look at the statistical analysis plan, again, for the definitions of the endpoints, but especially for the analysis models. We look at if there's a prior publication of the study design, we look at those to see how things have changed over time, and we look at trial registration. And we'll look at the DSMB charter, if there is one, to look at the interim analysis plans. The point is that we look at all of these to make sure that the manuscript accurately and faithfully and completely represents the design from the beginning, how it was implemented, how it changed over time, and that the analysis is loyal to the SAP, and that the SAP was not modified in response to data collected within this trial itself. The consort addresses specifically what's in the manuscript, but we look at all of these in assessing the overall integrity of the statistical design, implementation, and analysis of a clinical trial. So I'm going to quickly run through some self-inflicted injuries in manuscripts. I think it makes most sense for you to look at these when you're preparing a manuscript. So that's why I've been very pleased that Megan's willing to post these slides so you can refer to them later. So inconsistency, version control, and failure to include all elements required by reporting guidelines, those are pretty self-evident. Failure to explain differences between study documents, whether the study population and the settings match what you intended. The clinical importance of the primary outcome measure, especially with composite outcomes where the different elements may have different clinical importance. If you're studying heart failure and one of your outcomes is death and another one is a BNP measurement, you really have to argue, does it make any sense to put those on the same scale? I've already mentioned co-primary endpoints and the importance of realizing what you mean and communicating what you mean by co-primary, overly optimistic assumptions in order to justify a small sample size, poorly defined analysis methods, failure to adhere to the intention to treat principle or to explain how you're deviating from it and why, methods for handling and minimizing missing data, type 1 error control, including multiple comparisons and gatekeeping strategies, and unplanned interim analyses or failures to fully describe your interim analysis plan. In study conduct, try not to lose participants to follow-up. And if you have interim analyses, make sure that you have a well-defined, prospectively defined plan. All of these are related to staying loyal to your original plan. Don't try to be selective or reorder the endpoints that you report. Don't use a per protocol or as treated analysis unless there's a very specific justification. And as far as I can tell, the only uniformly valid one is as supporting analyses in a non-inferiority study. Post-randomization exclusions. Once you've randomized a patient, if you can't follow them up to their endpoint and include them in their treatment group, you should have a very clear explanation for why that's true. Your reporting should be complete and avoid spin. I've seen many manuscripts fail to get a request for revision, not because the data weren't potentially valuable, but because the results have been so aggressively spun by the authors that the editors, frankly, don't have the stomach for trying to get the authors to rewrite it to be a more balanced presentation of the results. Failure to address appropriateness of non-inferiority margins, that could be an entire presentation in and of itself. Last comment I want to make has to do with interaction with journal editors. If you are requested to revise a manuscript for publication, at that point, the journal and the editor handling your manuscript is invested in trying to get your manuscript to a point that it can be published in that journal. But it is just a request for revision. It is not a preliminary acceptance. And you want to be respectful and complete in your responses and answer every question raised in as agreeable and flexible a manner as you can possibly muster, which usually means letting any upset you feel over the details of the reviews wear off before you do a revision. And never try to do just enough to get something accepted because it's very obvious to the journals and it's likely to lead to them not giving you the benefit of the doubt. I'm going to stop there. This is my slide on sort of what goes into high quality statistical practice, and I will turn off my slides and I'm happy to take any questions.
Thank you, Roger. There are a couple of questions in the chat, and if anyone would like to unmute themselves and ask a question, I think you can raise your hand and I can unmute you, or I can promote you to a panelist and you can show your video. So Roger, do you want to address the first question? And I'm just going to see if Regina would like to speak to her point that she asked.
Sure. So I should warn you all that I have very strong feelings about the MRS because as I understand it, the differences in the value of the neurologic outcome to patients really vary by each level of the MRS. I'd like to think I'm a 0, but I would much rather be a 1 than a 2 than a 3, a 3 than a 4, and a 5 by 6. I'd probably rather be a 6. But the point here is that any approach to dichotomization pretends that the levels on each side of the dichotomy are all the same and of the same value to patients, and that's just patently absurd. And I hate having a statistical simplification force us into a position where we throw away information that's important to our patients. To me, it seems disingenuous and having some ethical concerns. I am particularly struck by this label of functional independence, which was a way of trying to label the better levels at the MRS as if they are a single category when we all know they are not. You are right that the MRS often fails the proportional odds assumption. There are ordinal models that don't make a proportional odds assumption. And then there are utility-weighted scales that actually try to approximate the value of the neurologic outcome to a human being that quantitatively capture the difference between the different levels. I think we'd all agree the difference between a 2 and a 3 is larger than the difference between a 0 and a 1, and you can actually quantify that. So in the sequence of different analysis procedures, I would say dichotomization is the worst. And I know that the FDA has been on record of supporting it, often based on the assumption that it's the only thing that clinicians can understand, which I believe is insulting and incorrect. I think the proportional odds assumption is surprisingly tenable. And if that's what you need in order to avoid dichotomization, that's fine. I think more sophisticated ordinal models that don't make the proportional odds assumption are useful backup models to check the robustness of your results to a violation of the proportional odds assumption. I think the most appropriate analysis is a utility-weighted MRS. I am well aware it's a very, very controversial area, and it would need another hour to discuss.
Thank you, Roger. Regina, did you have follow-up questions?
Thank you, Roger. That's super helpful. I don't want to get in the weeds of my specific question, but basically I had a manuscript where I presented the ordinal MRS acknowledging that it violated the proportional odds assumption, and then followed up with a second iteration using the proportional odds model. And that wasn't liked. And so I appreciate, I need to read this paper that Cliff added for this this kind of other way to show it. But I know a lot of us use MRS in our studies. My experience with utility weighted MRS was that it's mostly for clinical trial, like use in clinical trials, and I haven't seen it used like applied to observational data retrospectively or like post hoc. Do you see that?
Well, we certainly, when we have access to data sets that report the actual MRS for patients, we often then apply the utility weight structure to those to value the outcomes of the patients in observational data. And I don't see that it's conceptually any different than in a clinical trial. You know, it's such an interesting area in terms of human behavior, because the dichotomization is a weighting scheme. It just happens to be 1, 1, 1 and the rest zeros. It's a weighting scheme that none of us believe applies to anybody. And yet the utility weighted values that were used, say, in IceCap or have been used in say, being used in the STEP acute ischemic stroke platform trial, those are criticized because people say, well, they're not the right utility for any particular individual, and yet people are comfortable using something that's wrong for everybody. So I think we have to chip away at this. And I think there's no perfect answer. I would say that when you applied the proportional odds model and it wasn't liked, that depending on what was criticized, there may be some area for discussion and pushing there a little bit. Was it a journal or was it a grant?
It was a journal.
Did the journal want you to dichotomize? What did they want you to do?
They thought it was inappropriate to present the ordinal MRS at all.
What did they think it should be presented as?
Just presenting the dichotomies. They thought disclosing that it failed the Brandt test, what should have been the end of the investigation into using the ordinal scale.
Yeah, so it turns out that the statistical result you get when the proportional odds assumption is violated tends to be pretty robust. You rarely cause a positive answer to be negative and vice versa. But that's getting down into the weeds. There are a couple of journals that seem to have completely bought into this idea that because historically we've dichotomized, the FDA likes dichotomization, the fact that it requires many more patients and fails to balance beneficial effects at one end of the MRS against harmful effects at other areas. So for example, if you're doing this is truly a hypothetical example, please no one read anything into this. Let's suppose you're doing an endovascular therapy for very, very large acute ischemic strokes, or think of an invasive surgical procedure for deep ICH. There's no question some patients who might have survived with a 4 or 5 are going to die because of the procedure. So you'll see a shift to worse outcomes. And some patients may be helped by the procedure where they would have ended up as a 3, 4, or 5 and will end up with a better MRS. You want to have a pre-specified way of balancing net benefit and harm, and only a quantification of the value of each level of the MRS allows you to do that. The historical approach is to have a so-called efficacy endpoint and then a safety endpoint. And I've even seen people say, we'll dichotomize the MRS at, say, 0, 1, 2 versus 3 through 6. That's my efficacy endpoint. And then I'm just going to count deaths. That's my safety endpoint. And yet it's all the same part of the MRS. There is a death is a neurologic outcome, last I checked. And this is just an artificial structure to try to get around people's difficulty with addressing the entire distribution of neurologic outcomes and both benefits and harms on a single scale. And I just want to add, as and I realize I'm being sort of aggressive in my answer here, that when you approach a patient for a surgical intervention that has a high mortality, say someone has a complex aortic arch disease, and the thoracic surgeon says, if we do this procedure, there's an X% chance you're going to die on the table or we'll never get you off bypass. And if we don't do this procedure, this is what we expect for the natural history. Rational patients, and they're hopefully in concert with their providers, make decisions all the time about balancing harms against benefits. And we manage to make decisions, which means we have some sort of internal utility weight that allows us to balance the negative risk of death against the benefit of a better quality of life if you survive. There's no reason we can't do that for major neurologic disease.
Thank you. I'm totally with you. I would love to present, because I totally agree with you. There's so much information that is in the ordinal scale. That yeah, I would love to present that. I was wondering, and the other scholars are also wondering if you are open to having consults on some of our work.
Oh, absolutely. Absolutely. I would love to do that. My email is on the slide set. Megan knows how to reach me. If I send you an email, my cell phone is on it. I should be very easy to reach. Be happy to set up times to talk about these things. And just a shout out to NINDS. NINDS was fully supportive of the utility-weighted MRS as the primary endpoint for the STEP platform trial.
All right, I don't see any other questions. I know Cliff posted a paper in the Q&A if anyone wants that. And I also posted in the chat the link to the slides. So those are up on our website now. And this is also being recorded, so we'll get that posted in a couple of weeks. If there's any final questions, you can raise your hand now. I don't see anything. Roger, thank you so much. This has been extremely valuable. I know that people will probably revisit this a lot, so we really appreciate you coming and presenting, and we'll look forward to hopefully getting your consultation on other things soon.
Right. My pleasure. Thank you, everyone.
Thank you.